Okay. We discussed together a very important topic today because the emergencies is a very important issue for clinical provider with a patient with eating disorder because it arises many times. It is very heavy to manage. Thanks, Ashish, that presented the guideline published by the Royal Clinical Association of Psychiatrists in England, that will be introduced by Lia Manzato. Lia Manzato, she is a psychiatrist. She works in the northern part of Italy. She led the services for eating disorder in the wonderful city of Ferrara. She is member of the board of the European chapter. She published also recently a very important book about hidden disorder, that lesser known disorder that is important for every colleagues. And okay, Lia Manzato will introduce Ashish.
Thank you, Umberto. Welcome everybody to our European chapter webinar. I'd like to introduce Dr. Ashish Kumar. He is a colleague from England. He is past president of European chapter of Academy of Eating Disorders. Now he is a member of European chapter board. He is a fellow of the Royal College of Psychiatrists, consultant psychiatrist and clinical director of child and adolescent mental health services at MEED Care NHS Foundation Trust in Great Britain. He is also serving the Faculty of Eating Disorders of the Royal College of Psychiatrists as its vice chair and as incoming chair. In these roles, he has contributed to national and international policy developments, revisions, and reviews on eating disorders. He has been involved in development of curriculum for medical students and psychiatrists. Dr. Kumar is interested in creating systems, knowledge, and undertaking research in eating disorders and mental health. He has presented on important topics related to mental health law, eating disorders, and leadership at the international conferences and NHS national events. And he will talk about a fundamental topic as medical emergencies in eating disorders, guidance on recognition and management. Managing emergencies in eating disorders is a comprehensive guideline published by the Faculty of Eating Disorders of the Royal College of Psychiatrists, published in London in May 2022. Now we can listen to Dr. Ashish. Thank you.
Thank you very much, Emilia, and really appreciate. And thank you, Umberto, for giving me this opportunity to talk to colleagues from Europe and hopefully from the world. And many of them are from my team as well in Liverpool. And sure, it will help us to understand why recognizing and managing emergencies in eating disorders is extremely important. So these are my disclosures. I got some grants to, do some research, I would say, and I'm trying to implement a triangle intervention for children in my service and with Professor Janet Treasure at King's College London. And so in today's presentation or webinar, I will be focused on how to recognize signs and symptoms in children and young people who suffer from anorexia nervosa mainly, but other types of eating disorders, and how we could help them early and manage them. I would also be focusing on their psychological factors, because when you talk to children and young people and their families, they're just not individuals where you go and just fix the illness itself. You have to understand them. What is going on in their mind? What is the reason that illness has developed? What is the reason that they are not complying with your interventions, such as psychological intervention or meal plans, or sometimes medical interventions? So we need to understand them better. We need to be on the same page as the patients are and their parents are. Sometimes it works quite well. Sometimes we have to wait for right opportunity to engage the young people and their parents. Sometimes we have to push them in the way we want them to, start to comply and get help. Obviously, there are different types of skills we would need to engage our children and young people, and there are different types of legal frameworks sometimes we might have to use to engage them. So in the UK, of course, we have legal frameworks such as Mental Capacity Act, Mental Health Act, Children's Act 2004 and 1989, which also helps us to put the boundaries around young people and their parents to help them engage. So we'll talk about that and try to understand things better. So this is the area of England where I work currently with my colleagues. Quite a few colleagues are on this call as well. So our eating disorder service is called Mid-Mercy Children's and Young People's Eating Disorder Service. We cover a population of 650,000, spread over St. Helens, Warrington, Halton, and Knowsley. And our team is based in Knowsley Borough. And so we have created some systems for our children and young people. So patients can now refer themselves by self-referral mechanism. So we have a website, which is Mercy Care NHS Trust website, on which we have a web page for children's eating disorder. As you could see here, there are tabs here. We have prevention, assessment, intervention, transition, teaching and training and research. Tabs there on which if you click, you will be able to find some resources, including the MEED tool. Now, just for everyone's information, that MEED tool is now available on Royal College of Psychiatrists website and also European chapter website. So thanks to my colleague, Don Gannon, who had just uploaded it on there. So you can access those tools there without much problem. So on this page, you could see that we have created the system by which any general practitioner in our locality, our area, they can refer the patients directly to us. And there is a patient interface on this one, where patients can complete the self-referral form, their parents can complete. We have created the QR code. Patients can scan it on their smartphone, and they can just send information about them and refer themselves, and we will contact them, we'll book them in to come to our base to do physical health check and start the process of engaging them to our service. So we have made our front door very accessible to our patients and carers and also other professionals by creating these electronic means or digital means, which is really useful for them. So why we are thinking that we should be helping children and young people who suffer from eating disorders, and it is important to think about managing emergencies. My thinking is that before emergencies happen, we need to educate the young people, we need to educate the teachers, we need to educate the whoever is in the near vicinity of young people, which can be their parents, teachers, friends, families. And we need to educate everyone to pick up on the signs of eating disorders, such as food restriction, severe level of anxiety, hiding food, binging, purging, visible loss of weight or visible unwellness, which you can see in your child, in your friend, in your family, your daughters, your sons, of course. There are quite a number of males are now in our service. So you need to be visible. You need to think about that. What are the signs I'm looking for that will indicate to me that these children and young people are losing weight, or they are not doing well, or they are looking unwell, and they might need help. Unfortunately, in more recent years, since COVID has happened, and more recently in last few months as well, I've been getting more and more patients and young people who are coming to us at very low weight for height. So they are coming to us at very low BMI, like 13, 14 BMI, or weight for height terms, they are coming at 75%, 77%, or sometimes 70% weight for height. So quite a number of them are coming at very high risk category, which I will talk about in a minute. So the picture you are seeing on the screen was of Avril Hart, and she was a young girl who died at 19 years of age in 12. The reason she died, well, she suffered from eating disorders. She was going from school to university. She moved to university where, she started to hide from services. She would not engage much. And as a result, she started to get unwell. And unfortunately, we as a service potentially could have done better, but that is a separate discussion at this point. However, unfortunately, she died later on in the hospital. This death and quite a few other deaths led to Parliamentary Ombudsman report in UK or England, which led to some new funding for children's eating disorder services in 2015 and 16, which was predated by National Access and Waiting Time Directive document, which told us that how the children's eating disorder services should be set up. And there were lots of discussion and policy making and national level strategy meetings, etc., among different colleagues from NHS England, Royal College of Psychiatrists, Health Education England, and policymakers in Department of Health, and so on and so forth. So as a result of which we invested some money, we have set up 72 children's eating disorder services across the country. As a result, we have been able to improve the quality of care the children and young people are able to receive since then. However, our aspiration is to improve the quality of care which is being received by adults with eating disorder, and we would aspire that that becomes better as well. So this is Avril Hart with her father in the last few days of her life. So we want to prevent this kind of deaths, and that's why it is important we catch up our patients early and offer early intervention. So on this slide, you'll see that weighted mortality rates is 5.1 for anorexia, 1.7 for bulimia, and 3.3 for ADNOS. This is from 2011 study, and this is also tells us that out of every 5 patients who dies from eating disorder, 4 die because of physical health causes, mostly cardiovascular failure, and 1 die because of suicide. So these are the serious risks which we need to think about and worry about. Now, psychological changes we must think about when we think about eating disorder patients. Most of the eating disorder patients, and these figures are mostly from adult population, I must say, that by the nature of illness is such that eating disorder patients do not want to seek help. They try to hide. They don't want to be forthright. They don't want to engage with our services, our nurses, our GP colleagues, our psychologists, our therapists, or psychiatrists. They do not want to engage. They do not want to engage with our dietitians. And so that is one of the research findings as well. They don't seek help themselves. There is high dropout rate from inpatient and outpatient services. There's very high level of difficulties engaging them in treatment. So there has been lots of research in this area. Anorexia also functions like as a way of reclaiming control. So if you're thinking about a patient who suffers from anorexia, they have potentially, there are difficulties in the family. They feel that they're not getting the attention of their parents. They're not getting the attention of the teachers. They might be struggling in their relationship within the family. So illness behavior sometimes can be construed as, you're trying to reclaim the control in your family life. So these factors can play some part, not always very actively. In some cases, it could be one of the reasons. It is a self-punishing defense when you are fearing loss of control. So you try to punish yourself by getting unwell, and that could be one of the defense mechanisms. Sometimes it could be construed as a friend or enemy. I had many patients who would talk about anorexia as a friend. Some of them will talk about anorexia as an enemy, but they give some names to anorexia or their illness. So psychological changes happen in patients with eating disorders, such as change, and these are the psychological themes: security, control, avoidance, mental strength, skills, and communication and confidence. As a result of these factors, what happens is that they more often than not prompt care from others, which might be their friends, their family, their parents, their grandparents, or teachers. So everyone tries to, come near them, try to help them, try to have sympathy for them. Of course, many of us in this room who are working on inpatient unit in pediatric ward or outpatient clinics in children's eating disorder unit or general practice, you will see that anorexia patients start to think that they have a separate identity about themselves. They have got a badge, which is, okay, I have got this illness. And many times they do not want to lose that identity. Sometimes they feel they're different, they're special in some form or shape. Many times they lose periods, they are obviously getting thinner, and sometimes they think it is very positive because they do not want to go through the maturation phase after adolescence. They do not want to grow and go through the growth cycle. So those are the changes. And they also think that they have mastered how to remain, how to control their weight, how to keep everything under control. So they feel that they have this inner sense of strength, that in spite of being so unwell, they're controlling lots of things around them, and everyone is moving around them, or things are moving around them. So these are the psychological factors which can be. They also have ambivalence towards recovery, meaning that there is no straightforward answer that, okay, I'm unwell and hence I would get better. They think about it, they think whether they should or they should not. The voice in their head sometimes can tell them, look, getting better is not a good idea, where you are, it is fine, you can stay. So anorexia is ego-syntonic in nature. What it means is that you are not fighting. It is not someone else's thought. It is your own thought that, it is your own illness, which is in your mind, that you do not want to eat. So it is ego-syntonic in nature. So they are not fighting this illness to go against it, just to remember that. So this is the nature. And also drive to thinness is, is construed as being more attractive, more pretty, and hence more socially acceptable. Sometimes they're trying to work with their friend circle and, they're trying to impress maybe their male friends or friend circle itself, or going with the flow. So these are the ideas which they might pick up at school. So these are the things which are associated with psychological factors, which are associated with illness. And when you're trying to help children and young people with anorexia or eating disorder, you need to understand these factors. So they have weaknesses in visual attention, learning, non-visual memory, and executive function. So these are the cognitive changes which can happen. And if young people have weakness in their cognitive function, many times when you're trying to do therapy, you have to take care of that. The therapy is delivered at the right pace, at the right time. Because if you're talking about things and they're not able to focus, if you are not catching their attention, they may not get anything. So as therapists, as clinicians, we have to be aware of these factors. I will also like to bring in this discussion that genetic factors, which plays its own part in genesis of eating disorder or anorexia. So this was one of the massive studies conducted, and result came out in 2019 by Professor Jerome Breen and colleagues. And this study was done in, of course, in UK and US. And quite a number of patients were, included, and there were significant loci of genes were found out. So now we know that there is significant genetic element, and there is significant bidirectional causal relationship. And so we need to be aware of these factors when we are thinking. And sometimes our patients will ask whether I am to blame or it is something else. So I already talked about that, how we did things differently in our service and how we wanted to get it better for our patients and carers. So this is the MEED tool, which has been now published on European chapter website and also Royal College of Psychiatrists website. It has been created on the basis of managing emergencies in eating disorder guideline, which came out in May 2022. And after quite a lengthy and detailed process of producing that guideline, but this tool gives you a traffic light system whereby in a snapshot, you can look at this tool and think where your patient is, whether they are having high impending risk to life or there is alert to high impending risk to life or low impending risk to life. Yeah. So these are the three categories. And this tool has replaced a tool which we had for last 6 years, 7 years, which was based on junior marzipan guideline, which was there since 2012. And also we had adult marzipan. So those two guidelines, adult marzipan and junior marzipan, were merged, and we revalued everything, we reevaluated everything, and we then wrote Managing Emergencies in Eating Disorder Guideline. And as I said, it was published in May 2022. So this tool has been disseminated in England and through websites. Obviously, people can access from all over the world. But there was lots of positive feedback since we got this tool published from the clinicians, from the patients sometimes, because sometimes patients have been given this tool. Obviously, we have told our patients to interpret it with caution and always talk to a clinician before they get panicky about many things which is written on this tool. So if you look at this tool, there is a physical health risk rating on one side, and then there is psychiatric risk rating on the other side. And you can see that BMI less than 13 in less than 18-year-old patients, or weight for height less than 70 is considered as very high impending risk to life. So that is one factor, which is based on BMI or weight for height. If there are weight changes, and if someone loses 1 kilogram of weight or more every week in last 1 week, that is very high risk in itself. If heart rate is less than 40 beats per minute, that is high risk. And if there is a heart rate change from sitting to a standing position of more than 30 beats per minute, then that is also high risk. And if there is blood pressure change of more than 20 millimeter of mercury between sitting and a standing position, or if there is systolic blood pressure is less than 90 millimeter of mercury, then these are high risk or high impending risk to life. So these are quite significant finding there. If someone is having recurrent syncope, that is also high risk. There are some ECG changes which have been mentioned on this tool, as you could see there. And hydration status, if someone is severely dehydrated, and if they have lost 10% of urine output, and they have dry mouth, reduced skin turgor, and sunken eyes. So those are very significant changes which you need to be thinking. If they have 35.5% degree centigrade or less temperature, so that is hypothermia, you need to be worried about your patient. If they have hypophosphatemia, if they have low potassium level at less than 2.5 millimole, and sodium level also if that is low, and if you have low calcium level and magnesium level, those are considered as high impending risk to life. Deliberately, no quantity was put for those sodium, calcium, and magnesium changes, purely because that has to be taken care of in association with other signs and symptoms, such as restriction of food, dehydration. So just to be aware of that, one red sign is not enough to say that someone should be sent to A&E here and now. You have to get the whole picture. So if a young person or child is not complying with their meal plans, or they're shutting down completely, they are not eating and drinking, and you're worried their blood pressure, pulse, everything is getting haywire, and they're losing weight at a high rate, then you should be worried about, and then we should think about either sending them to A&E, and in some cases where the services are there, such as in our service, we have direct arrangement with our pediatric ward that we can go for planned admission and management of such patients. On the right-hand side, when you move, you have amber zone and then green zone. So as the risk goes downhill, you would worry less about such patients, but nonetheless, many patients will need long-term treatment. Now, glucose level, we used to say that if it is less than 2.7 millimole per liter, then that will be high risk. But this time we changed it to 3 millimole per liter after doing lots of literature search. So glucose level, if that is less than 3 millimole per liter, then it is high risk again. Now, coming to the psychiatric risk rating side, if you look there, if patient is restricting food, so that used to be less than 300 calories to be counted as high impending risk to life in last 2 days. We changed it to less than 500 calories per day intake would be construed as high impending risk to life. So threshold have changed, just to remember those factors. Engagement with management plans. So if patient is not engaging with their parents and carers in their meal plans, there is constant fight, there is constant argument, they're exercising quite a lot, and their food and fluid intake is quite low, their insight into their illness, their motivation to change is quite low. Those factors would be construed as high impending risk to life. For example, if someone is exercising for more than 2 hours every day and it is continuing, then it becomes high risk as well. And if they're showing severe purging and binging behavior, that could be considered as high risk as well. Similarly, self-harm and suicidality, if that is being presented by the patients, because earlier on the slide I showed you that 1 in every 5 deaths happens because of suicide. So we need to be worried about such patients who are presenting with high risk of self-harm or suicide. There are other medical conditions we need to think about, such as diabetic ketoacidosis and alcohol consumption or drug consumption, and any other physical condition as well, such as if they're having blood test changes and you find that their liver is not functioning well or kidneys are not functioning well, they are showing signs of dehydration as urea level is quite high, creatinine is quite high. You need to then worry about such factors. So this tool tells you in a snapshot what you need to see and what you need to worry about. And so at this point, is there any question from anyone, Emilia, about this tool itself? Then I will move on. You're muted, Emilia.
Sorry. No, I think it's better to go on with this explanation and then take the questions at the end of your presentation. Thank you.
Okay, no problem. Thanks. So I will go on to talk about what changes happens in patient's body and how we could recognize them and how we could help them. So as you know that when patients do not eat, there is nutritional deprivation or a starvation. Can you hear me? There's some noise in the background for some reason. So if a starvation is happening and there are hormonal changes in patients, so patients are in a state of catabolism or there are adipose tissues and muscles which are being used up. So in earlier starvation, the body switches from using carbohydrate to using fat and protein as main source of energy, resulting in loss of lean body mass. And as a result, they are declined by 20 to 25% in basal metabolic rate. And that is quite significant. That's why patients start to feel cold and they start to get unwell. The muscle breakdown starts to happen and water and mineral depletion starts to happen as well. As a result, there can be concurrent changes in phosphate, magnesium, calcium, sodium, and potassium as well. Vitamin and minerals also start to reduce. And that's why when we see patients in our services, we start to put them on multivitamin and multiminerals so that initial risk because of changes in vitamin and mineral level reduces significantly. And so there are 2 types of significant changes, significant risk to patients. One is because of direct consequences of anorexia nervosa, when they're not eating well and there is low body weight. and also because of changes which can be brought up in their body and psychologically as well by vomiting and purging quite significantly. Then there are complications because of treatment. So once they have been started on treatment, they can have refeeding syndrome if that is not well taken care of. So these are the main concerns as clinician you should be thinking about. So there are changes in the heart. So there are cardiovascular compromise, which occurs early in up to 87% of the patients. So most of the patients who suffer from anorexia and they're having low weight for height or low BMI, you will see that their heart muscles have reduced. So size of the heart reduces as well. And we have seen in some research which have taken the pre and post a scan of their heart. It has shown significant decline in the size of their heart. There are valvular changes in 60 to 65% cases. As you could see, that 30 to 62% of cases, there are mitral valve prolapse. And as a result, sudden cardiac death can happen in this patient. Bradycardia, which means that heart start to beat slow, can happen in significant number of patients. And postural hypotension, which means that their blood pressure goes low when they start to stand up from sitting down position. As a result, they can have blackouts or syncope. So these are very significant events which happens if they are not eating very well. QTC prolongation on ECG or other changes. Of course, I will advise you not until unless you are having experience in ECGs, you should seek help from qualified pediatricians or GPs or your medical colleagues before you try to make decisions on those, or a doctor in your team or a nurse who is experienced to look at the ECGs. And these are the other changes: first degree heart block, low voltage changes, T-wave inversion, ST segment depression, because of electrolyte changes can happen and can be noticeable on ECG. I mentioned about syncope already. Hypertension, peripheral edema. We do see in some patients that there is edema in their feet or back of their hips, and effusion in pericardial effusion and congestive cardiac failure, especially patients who are not treated very well, or they do not reverse their weight loss or come back to normal weight for height range or normal BMI. These changes can be quite serious. So we need to be very careful when we are managing patients with severe eating disorder. At this point, I also wanted to bring in, there are changes which have been made in ICD-10 to ICD-11. So in ICD-11, which was published in January 2022 and came into focus, we have severe or dangerously low weight anorexia nervosa. So they are now using term dangerously low weight anorexia nervosa in ICD-11. And in that category, you have BMI of less than 14 or percentile BMI of less than 0.3 percentile. So these are the very significant changes which have been made in ICD-11 compared to ICD-10. Because in ICD-11, now people can look at it and decide whether it is severe or dangerously low. So these are very significant words which have been used there. And those patients should be considered for treatment as inpatient if you feel that they're not motivated to engage in outpatient care. So growth and development can be affected in children with eating disorders. Pubertal and growth delay is quite common. Primary amenorrhea due to luteinizing hormone and luteinizing hormone, releasing hormone because of malnutrition can happen quite clearly. Delayed bone and mineral accretion and increased frequency of stress fracture in the bones are very common in children or even adults. So that calcium deficiency and vitamin D deficiency, if that is not corrected, can cause lots of difficulties in their physical health and eventually mental health as well. Just to remember that, because low vitamin D has been associated with depression as well. So you need to be mindful of that. So there are fluid-related changes and changes in kidneys as well. So in 70% of cases, patients have been seen to suffer from dehydration. And as a result, GFR, or glomerular filtration rate, reduces quite significantly. Level of urea has been noted to increase, and as a result, there are some hormonal changes because of which patients can pass urine quite frequently or can have polyuria. Low calcium level can lead to muscle spasm, tetany, stridor, and seizure. Low sodium level can cause seizure, coma, and death. Low potassium level can cause arrhythmia, poor gut motility, skeletal muscle changes, myopathy, weakness, and nephropathy as well. And low magnesium level can cause muscle cramps, weakness, irritability, psychosis, seizures, arrhythmia, and it can be associated with low calcium and potassium level. Low phosphate level can cause muscle weakness, paresthesia, and central nervous system disturbances as well. Many patients who are not eating, it can lead to size of their stomach reduces quite significantly. So what it will mean is that, and the walls of the stomach become more firm or less elastic. As a result, when children or young people or adults even start to eat food, they feel bloated because the elasticity of the stomach is reduced or lost sometimes. They cannot expand. As a result, they might feel bloated. And sometimes, because they're not eating enough, the bowel movement becomes weaker. As a result, they can have constipation. Repeated purging or vomiting can lead to esophagitis, meaning that they will have inflammation of their esophagus, and it can lead to dental erosion because of acidity and enlarged salivary glands. So these are the changes which can be visible in eating disorder patients. Abnormal liver function has been noted. So liver enzyme changes I have noted quite a lot of times when I see patients with eating disorders. High cholesterol level can be present paradoxically, because you will think that patients are thinner or underweight, hence their cholesterol should be normal. But in some cases, I have seen high cholesterol level as well because of lots of disbalance of chemicals in the body or hormonal changes. Pancreatitis or inflammation of pancreas can happen. Low hemoglobin level is quite common, and low platelet level I have noticed. Pancytopenia in very severe cases, meaning that bone marrow failure starts to happen. And as a result, there are global changes on the patient's blood picture. Coming to some other points here, talking about bone health, it is quite crucial for patients with eating disorders because they are 3 times more likely to have fractures in cases of anorexia nervosa. And the mechanism are 2 actually, because if they have low BMI, it affects their bone maturation. And if they are having amenorrhea, means that the hormonal changes because of low estrogen and progesterone can cause problem with bone maturation and bone density as well. As a result, there can be higher chances of fracture. So if you look on this slide, you will see that because of this low or lean body mass, there is hypogonadism. What it means is that there is low estrogen and progesterone or androgens as a result. So bone accretion, which means that bones becoming mature, is affected. As a result, there are higher chances of bone fracture with a small knock. So that's how it happens. So if you look on this slide, so low BMI and decreased lean mass can be associated with decrease in surrogate markers of bone formation and bone resorption. And low bone density can impair bone microarchitecture, low rates of bone accrual. So there's low accrual rate of the bones. As a result, they're not maturing properly. And that can lead to pathology, as in they would become very weak and spongy, and a small knock can cause the bone fracture. On the right hand of the slide, you will see that low leptin, high adenopectin, and fat mass, low levels of amylin and insulin, those hormonal changes, decreases surrogate markers of bone formation and increases in surrogate markers of bone resorption, as a result of which low bone density, impaired bone microarchitecture, and impaired bone strength happens in adults. So on right-hand side, the changes as it happens in adults, and left-hand side, the changes as it happens in adolescents. So these are the common changes which can lead to bone pathogenesis and pathology, which can lead to fracture. And in children and adolescent population, if they're not having proper bone maturation, they do not grow properly. They're left with long-term damage to their bone growth and can be left with poorly formed bone and hence lots of pain. Also, the changes which happens because of poor hormonal changes or hormonal changes, such as they are not having enough menstruation. So there could be primary amenorrhea, so there was no menstruation by 16 years of age, or secondary, meaning that they had menarche, but they were not having any periods after that. In anorexia, both cases can happen because sometimes the anorexia starts before 13, before they had menarche. So in hypothalamic amenorrhea and polycystic ovary syndrome, and both periods are missing, and there are multiple follicles on ovaries. So if you see that they are losing weight and they lose weight by more than 10 pounds, and you can see that there are stress fracture or low BMI, restrictive eating habits, regular exercise, and chronic or acute stress. And hyperprolactin can cause amenorrhea as well. So if they are on some medications like antipsychotic medication or antidepressant, which do raise level of prolactin level, in those cases, you have to be careful that what can cause amenorrhea, and you have to rule those things out. But if this is a case of primary amenorrhea, where patients do not start to menstruate in the first place, you have to see whether they need to be brought back into normal healthy weight for height range, such as 95% to 110%, when the chances of them starting periods increases compared to they're left underweight and they're not increasing, coming out with their periods. So looking at this slide, and this is if you look at on this slide, this explains that how low estrogen and testosterone level, and how the control of hormones plays their own part in causing hormonal disbalance, and as a result, amenorrhea can happen. So when patients lose weight by more than 10 pounds and the BMI or weight for height goes down and down and down, then how it messes with everything, which can lead to amenorrhea or loss of periods. And in long run, it can cause infertility in patients. So just to be mindful of those. So there are emotional changes as well because of loss of periods, not just a problem with bone maturation. There could be night sweats, loss of sleep, frequent awakening, and more irritable mood. Osteopenia, which can happen as well because of low estrogen levels. So these are the important changes which happens because of patients not eating or not eating enough. There are lots of other psychological changes, and on this slide, if you look, their parents are very concerned. They have growth problems, pubertal delay, adolescent failure to thrive, abnormal diet and weight loss, vomiting. They have excessive exercise, and some of the other changes we talked about. Of course, I will come to some of my other slides to discuss that what are the other changes we need to look for. But most commonly, the patients can be very emaciated. They have sunken cheeks, eyes, sallow, dry skin, and flat affect. On this slide, you can see how growth charts are used for children, both boys and girls, to find out which area of the growth chart they are, and you can use this to find the link between not eating and poor growth as well. So I'll come to some other slides, and on this slide, actually. So if you look on this slide, in one single snapshot, you can find out how when you are not eating well and anorexia is happening, You can see the signs of emaciation in this patient, dehydration, hypothermia, short stature and delayed growth on one hand, dry and cracked lips and tongue, ketosis, scaphoid abdomen, and palpable constipation. Skin changes, pallor, lanugo hair, thinning of scalp hair, dry skin, brittle nails. Those changes can happen. Psychological changes such as mood, depression, anxiety, many times OCD kind of symptoms are associated, loss of rigidity, the way they think, the way they behave, the social relationship, which is not on this slide, but social relationship, family relationship is a massive, massive casualty of these illnesses, besides the heart changes, which has been mentioned on this slide, such as arrhythmia, hypertension, mitral valve prolapse, cool extremities, and edema. Muscular atrophy, diminished deep tendon reflex, peripheral neuropathy are some other changes. On this slide, you can see that how parotid gland, which is just in the angle of your mouth or near the, just below the ears, it can become quite enlarged, and some mandibular gland just below your jaw could be also palpable too. Muscle wasting, I had some patients who came, and one of my nurse colleagues got them with the governance permission. We got them photographed, and what you are seeing here is exactly how we saw. And our medical photography department has taken lots of pictures, and the changes which has been noted. You can see here the lanugo hair, very fine hair here on the skin, and emaciation and muscle wasting, which you can see the signs of. Edema, pedal edema here, you can see the changes there. Russell sign is one of the very important signs in anorexia or bulimia when they try to put their hands down their throat to induce vomiting. As a result, the back of the hands get callosity, which is called Russell signs there. Slow capillary refill, acrocyanosis, as you could see here, which is quite fine-tuning your clinical skills. You need to find out. Bluish discoloration and lacy pattern on your arms, which is called livio reticularis, which gives a mottled skin color here, which can be noted. Changes in your tooth. So if they're making themselves sick time and again, there is loss of enamel of teeth, and teeth become quite yellow and can lead to tooth decay, fracture, and loss. That's why we sometimes have to refer our patients to dentists. We also do SUS test. SUS test is sit-up test and a squat and a stand test. And so highest score or normal score is 3. If patients are scoring 0 or 1, then that means that they are not performing well. So patient is asked to sit up on the floor, a squat on the floor, and then they ask to lift from that position, stand up from that position without any support or help. If they are able to stand up from that position, then it is we are scoring 3. If they cannot, then it is 0 or 1. If they are struggling, and that is significant, that goes in the red zone of MEED tool, which I shared earlier. A squat and a stand test I have already described, and when they are lying down on a couch and you ask them to sit up from the lying down position again, if they are not able to sit up or they need help, then it is 0 or 1, and if they can sit up without any help, then it is 3. So these are the changes which you can see. Again, investigations, we do lots of investigation in our patient when they come up. We do the full blood analysis, we do ECG, we do physical health check like blood pressure, pulse, we do clinical examination, and of course we check for vitamins and minerals as well, so that we are very clear that what are the deficiencies, we try to correct them. And of course we look at liver function, kidney function, and ECG as well. So I would not go too much detail into management, but I will take this opportunity to highlight some of the factors here, that there are different types of mild, moderate, and severe dehydration, which needs to be looked for and treated. And So mild dehydration is about 5% of restriction of fluid intake, 5 to 10% is moderate, less than 10% is severe dehydration. And that severe dehydration comes into high impending risk of death on the red zone of MEED tool. So if you see any of these changes, reduce urine output, dry mouth, reduce the skin turgor, sunken eyes, and tachypnea and tachycardia, then you need to worry about such things and need to correct it. So on this slide, you will see that what are the signs and symptoms of mild, moderate, and severe dehydration, and how you try to correct them. And you can see the signs of hypovolemic shock as well, which is, of course, a medical emergency, which you will not treat in community. You will admit the patients and try to rehydrate them. Resuscitation, obviously, it is for people who are trained in this area. So I would not want everyone to think about it. But if patients are showing very inappropriate normal resting heart rate, and if their heart rate is extremely high or extremely low, I have already talked about that. If heart rate is less than 40, that is red zone of MEED tool. You need to worry about that. You need to think about accident and emergency department, and that's where they should get help. Again, on this slide, blood glucose level, if it is less than 3, it has come into severe, and higher than 3 millimole per liter, it is in normal zone as well. Again, but whenever this happens, we try to treat it by asking patients to eat regularly and eat very well. And sometimes if patient's blood sugar is going down to 2 or below, you will treat them as an emergency, just to say that. Of course, if there are electrolyte imbalance, you will correct them as well by nutritional correction or by giving them supplements for sodium and potassium and calcium, magnesium, etc. Quite a number of my patients who are treated, they're given supplements, and we work very closely with our GP colleagues to start them on treatment. We have in-house pediatric colleague, Dr. Ahmed. And I want to thank him, Dr. Ahmed, as well, for lots of this discussion, which I'm talking about today, which over the years has helped us to understand these physical health changes quite a lot, and how to help them. Now, refeeding syndrome, which is quite an important point, which we want to know today, is that refeeding syndrome is a syndrome which happens after patients are started to be refed. So if someone has not been eating and has been restricting for a significant number of days or weeks, and their weight for height or BMI level is quite low, or if they have been losing weight at the rate of 1 kilo per week for the last couple of weeks, and you then start to feed them, then it can lead to re-expansion of intracellular space. As a result, there is sudden increase in demand of vitamins and minerals because there is increased load on the system. So heart muscles, your other muscles are looking for calcium, phosphorus, magnesium, and sodium and potassium to metabolize the food and also to keep pumping, keep working. As a result, lots of these chemicals are taken in the intracellular space. As a result, there is a sudden decline in this chemicals concentration and can lead to serious condition called refeeding syndrome. So as you could see on this slide, that if weight for height or BMI is quite low, and if they have not been eating or they'll get more than 1 kilo for 2 weeks, or they're eating very less, or their calorie intake has been 400 to 600 or less. Electrolyte has to check again his blood test is important, neutropenia, or previous history of refeeding syndrome. So these are the risk factors which people can think about when they are having, if they're binging, infection, multiple organ failure, etc. So what happens then? So there is sudden fall in phosphate level, and then there is changes in potassium level and magnesium level. So these are the changes. You will see changes in glucose metabolism and thiamine deficiency, and changes in liver function test as well. So, and then there will be fluid balance abnormalities as well. And this can lead to cardiac, respiratory, neuromuscular, renal, metabolic, and hematologic, hepatic, and gastrointestinal problems in the patients. So they can have very fast heart rate, or called resting tachycardia in these patients. They will have swelling in the legs, and they will have changed sensorium or confusion or altered conscious state. So these are the changes which will be noted, and this needs to be treated in emergency. So the patients can develop delirium or visual or auditory hallucination, dyspnea, paresthesia, generalized weakness and fatigue, peripheral edema, and seizures and coma. And patients can die. But thankfully, in my clinical experience, because we start to check blood test and ECG of the patients, we start to cover them with vitamins and minerals. Clinically, it is not very common, thankfully, because there is more awareness among the patients and their families to start feeding them regularly and start to check on their blood tests and ECG, etc. So these are the clinical conditions, thankfully, have not become very common, or is not very common. So, but refeeding syndrome, if it is not checked, if it is not treated, can result in cardiac failure and death. And hence it is important to understand. Of course, some other slides you'll see here is about acidity, about erosion of gastric mucosa because of vomiting, that how vomiting can cause problem here and how we can reduce it. And okay, so these are other things on the slides. And then how to treat the patients to improve upon their hormonal changes, their weight changes, their bone maturation, and help them to get better. And what we can do to supplement, and what is the best way to ask them to eat. I'm sure you all know that quite well, that making our patients to start to eat regularly and eat regular, suitable amount of food or healthy amount of food is the solution. How you reach that, whether you use therapy, as in family therapy, CBT, medication to help them with comorbidities or treat their depression, anxiety, etc. as well. So a cumulative effect is always useful. So I will stop at this point, and if you have any question, do ask me.
Thank you, Ashish, for this wonderful presentation that underlines the complexity of anorexia nervosa and in the emergency. If are there some questions? I'd briefly like to ask you, Ashish, what kind of help the risk rating tool can give to general practitioner and pediatrician to have an early diagnosis before to arrive in the severe conditions?
Yes, so what we have done, Amelia, is that in our area where we work, we have gone to our general practitioner colleagues, we have gone to our pediatrician colleagues, and we have undertaken lots of information sharing and dissemination of this tool. We have talked to them, and because, as I mentioned earlier, that just having one thing is not in itself is the problem. Having lots of changes at the same time could be the main thing. So we have gone to our colleagues and we have said, look, if you're looking at this tool here, there are changes in BMI, weight change, heart rate change, syncope, blood pressure, postural drop, ECG changes, hydration, temperature, and electrolyte and mineral changes. So we have asked them to look at these changes and see how significant are the changes. So we have not left them alone. We have asked them to talk to us. And so we always work together. We have asked the GP. So we have developed some referral form which GPs need to complete and send to us about patients, which I shared on my presentation earlier, the electronic referral form. They need to complete lots of information there. So once it comes to us, we make a decision that whether his patient is high risk or moderate risk or low risk, and then we triage triage them, and we bring the patients for physical health check with the help of our nursing colleagues or our assistant practitioner colleagues, and then we suitably assess them. So we have a deadline to see urgent cases in 5 days and non-urgent cases within 4 weeks. But more than that, if patient is severely unwell, so if someone has high impending risk to life like this one, and quite a few of these criteria are met, then we offer them pediatric admission as soon as possible to start them on refeeding program or weight restoration program very fast, and we do not wait for them to become unwell, more unwell. We want to help them sooner rather than later. So that's how we try to get them better sooner, by working with pediatricians and GP colleagues as well.
Yeah. Thank you, Ashish. I think we have no time for other more questions because we finished our time. I thank you very much for your wonderful presentation, and I thank all the participants of this webinar. Thank you all for your presence. Ciao, Ashish. Hi.
Thank you, Amelia. Thank you, Amelia, and thank you, Umberto, our president of the European chapter, for organizing this webinar series, and thank you, European Board of Directors, for eating disorders as well. And thanks for continuing the good work. So really appreciate, hope it was helpful. Thank you.
Thank you, bye.
Okay.